So I'm going to share with you this presentation on women's cancers and focus on a diagonal approach. And as you can see, I need glasses for the presentation, but not for actually reading the rest. And I wondered, do we have a handheld, actually? Great. So, on, done. Okay, if you get this message, then we get the rest of the presentation. I like to call it la neta. The bottom line is this. So, closing divides around women's cancers is a health, equity, and economic imperative. It is affordable and achievable through diagonal approaches and synergistic strategies combining women's rights, health, and cancer platforms need to be developed and implemented. I'll speak to that in different ways throughout the rest of the presentation. But the first part of our presentation is about a journey that we've taken as a family, a journey I've taken as a patient, a journey as a couple, and how that journey taught us to think about cancer divides and understand the obstacles that face women in cancers, particularly in Latin America. This photo is particularly important to my family and to me, and that is because not of me in the picture, showing that I still try to look like I did when I was about a decade younger, but rather because of the painting that's behind it. And that painting was painted in 2007 by our daughter, Hannah Sophia, who at that point was 11. Hannah is now 20. She's proudly, for us, studying here at the university in pre-med, and I know will become a wonderful physician. She is also a painter, as you can see, and what Hannah painted at that moment was what she felt was the lifeblood of her mother, which emanated entirely from my hair. And yet, only a very few months later, in a small primary clinic in Cuernavaca, Morelos, Mexico, our home, your home, I was diagnosed with invasive stage 2 breast cancer. Our younger daughter was 3, and as is the case with many women premenopausal in my early 40s, it was my baseline mammogram. I went through the rounds of surgeries and chemotherapies that are pretty typical of what any premenopausal woman, and many of them are patients as well who have gone through this, who are sitting with you in this audience, many of us have had to go through. There are rounds of surgeries, in my case, that led to a left side mastectomy, failed attempts at reconstruction, rounds of chemotherapy, 16 to be specific, and then 3 years of treatment. We faced this as a family, and we wrote a book about it. There is Hannah writing with me. Usually what Hannah wrote were admonitions, where she would say things like, hair is not alive, Mom. I had looked at the science. But she helped me to work through that book, to write that book. In many senses, she's a co-author. And that book speaks, though, to much of our family's experience, how we learned to laugh at the disease, how we learned to manage the fright and the fear of the disease, how we managed to learn and manage the day that the little one, that Mariana, thought that I looked like a vampire, a bald vampire, as I proceeded to lose my hair. It also talks in depth, and this has a lot to do with what you'll hear in the rest of this symposium. It speaks about our journey as a couple. As many of you know, Julio, president of this university, Julio Frank, in 2007 had just completed 6 years of his term at the head of Mexico's health system as our Secretary of Health, and had put forward the Seguro Popular with President Fox. He had just completed, and a few months later, what he'll tell you later this afternoon, is that he changed the sides of the bed. He went from being a leader of a health system to living and learning about a health system by literally getting into that bed with me and being with me in every chemotherapy infusion, staying with me in the hospital, on the floor, often on a little couch, there beside me every evening through every surgery where I lived through in that hospital or that set of hospitals. He'll share what it meant. He'll share later on much of what he learned. He'll share these strong ideas about how women are more than her breasts that John was speaking to as well. But we fundamentally are researchers. We're students of health systems. And so we looked at the data. And we went around the world looking at that data. And we found that breast cancer in particular had been truly an ignored challenge to the health of women in countries like Mexico. We saw and we knew about cervical cancer as being a tremendous challenge, particularly the health of the poor, but there was this very false assumption, a myth, that breast cancer only affected wealthy women and not the poor in the country we called home. We started an NGO called Tómatelo a Pecho that John also referred to. It was Julio's brilliance in developing that name. It's been used around the world for breastfeeding, but never for breast cancer, as far as we know. And we are very pleased that John is going to take that up as a lemma around women's cancers. Now, I told you that we focused on the evidence, and we did look at the numbers, and I'll share the numbers with you in a minute. But when I was thinking about this presentation, I realized that really nothing I'm going to tell you I didn't learn from this woman. We'll call her Juanita, and I met Juanita in a hospital about an hour and a half from the clinic where I was diagnosed with that mammogram that probably saved my life. And when I met Juanita in this hospital, she was receiving chemotherapy. It was a small, relatively small hospital, actually a women's hospital. Maternal and child hospital, our district hospitals, that was just entering into trying to support women through breast cancer and other kinds of cancers. Because the women, although they were supported and insured through the Seguro Popular that I'll tell you about in a minute, they couldn't afford to travel. They couldn't pay, as Debbie was referring to, for the care, just to travel for the care that they needed to receive. Now, when I met Juanita, I walked in, and you can't see it well in that photo. Not only can you not see her face, which is deliberate, but you can't really see that one side of her body is much, much larger than the other. And I walked in, and I assumed, falsely, that she was mastectomized like me. And so I walked in and tried to give her that survival trip, that you could do it, that she could do it, that I had done it, that she could manage her mastectomy. And she said to me, basically in best Spanish, ¿de qué me estás hablando? What are you talking about? So I thought, it's the word mastectomy. No? And I said, the surgery to remove your breast. And she said, no surgery, just this red liquid that they're giving to me. So the doctor explains how she got there. And here's the story that taught us a lot of what we continue to work on. So Juanita arrived at the hospital for care, not because of the grapefruit-sized lump that she had in one of her breasts, but because that grapefruit-sized lump was so large and obstructive that it had generated serious lymphedema and she couldn't move her arm properly. So by the time she turns up at the hospital, she's clearly stage 4. The hospital is doing everything they can, even though they're not covered by the Seguro Popular yet. There's an NGO that's paying for her chemotherapy. They're trying to bring down the size of that tumor so that they can actually manage the surgery. And she won't go to Mexico City to get the rest of her care for 2 reasons. It's not only the bus fare, it's that she has small children. She has no one to care for those small children. And why not? Because her partner has abandoned her as a result of the deformity and the diagnosis of the cancer. So she's left alone battling this disease. She can only be gone during the day. She has no place to leave her children, and she's not fully cognizant of what's happened. But then I realize that we have a very extensive, well-written, well-evaluated primary healthcare system. You'll hear more about that through the day. And she had gone through our primary healthcare system. She had gone through our social welfare programs. She had gone through all of the places that should have early detected that cancer. And at least, if not in stage 0-1, there was no excuse for any physician, nurse, or health promoter not having picked up that tumor before it got from the size of a grape to a grapefruit. But that was what had happened. And as we studied this, we learned that it was because our primary care physicians assumed that no poor woman would have breast cancer, that our promoters had no knowledge, that our existing social welfare and anti-poverty programs didn't say anything about breast cancer, although they did about cervical, and that she was frankly the process of a series of sadly missed opportunities to early diagnose her cancer and get her the treatment she needed. She went through treatment, but not surprisingly, she did not survive, and a few years later, she died of this disease. Now here's the summary of what went wrong, and it's a summary of gender discrimination, it's a summary of poverty, it's discrimination, machismo, low self-esteem, stigma, illiteracy, abandonment, lack of information, she and the provider lacked information, lack of access to early detection, the distance, and frankly, the poverty that she had to continue to live through. So that journey taught me pretty much what I'm going to tell you about in numbers and with programs. But the reason that I wanted to start with a story like that was because we believe that there is a duality between evidence or research and advocacy, that one of those false dichotomies is in fact splitting up advocacy and evidence, and that they need to be brought back together because we must have evidence-based advocacy, else we make mistakes in what we tell women to do. And we must have evidence that is inspired by advocacy, else it will not be as impactful as it could be, nor will it get where it needs to go. And if we effectively combine these, we believe that we get much better policies, programs, and projects that we need for this disease and for many other aspects of global health. Now, let me go through some of the numbers. And there's only two parts to the rest of the presentation. First, we'll go through the health, equity, and economic imperative of women's cancers. And then I want to share with you a bit of a smorgasbord of innovative, synergistic solutions that exist and that must be implemented, scaled up, evaluated, and made much more robust. First, we need to think about what happens to women across their life cycles and in our world. Julio will tell you that we are victims of our success. And this is what you see with these numbers. So first, we have seen in the last 30 years an enormous reduction in the number of women who die in one of the most dangerous days in our lives, which is childbirth. Having had that, having gone through a major intrauterine hemorrhage after childbirth, I know that if you are not cared for properly, you do not make it through that day, and that more and more women around the world are in fact having access to the hospitalization care and prenatal support that they need to be able to see that number go lower. Anna is one of the world's experts on this. I will just tell you that it's dropped 30%, but that it is still true that almost 300,000 women, almost all of them in the most impoverished parts of our world, continue to die at childbirth. But for the many who do not, they live to face other diseases: cervical cancer, breast cancer, diabetes, those chronic or non-communicable diseases that we need to treat. It's a much more complex journey for the women and for a health system. And what you see is we actually have many more women dying today in our world, like double almost, from just those three chronic or non-communicable diseases. The message here is not that we did enough to prevent women from dying at childbirth. The message is that it makes no sense to save a woman at childbirth and have her die of a preventable cervical cancer or a treatable breast cancer or a manageable case of diabetes, right? The message is we have to do that. The message is that our health systems have to live up to this complexity of challenges. Now, that complexity of challenges is the result of a very rapid and profound demographic and radiological transition. Those numbers are for the Americas, for Latin America and the Caribbean in particular. And what you see is an inversion in the causes of death. We went over a couple of decades through what Europe, North America took centuries to go through in terms of a process of population aging, but also the fact that the vast majority of the mortality we see is associated with non-communicable diseases and to some extent injuries. Now, when you look at cancer, women's cancer in particular, it just parallels that epidemiologic transition. But what it means is that the cancers that increasingly face the poor are not the only cancers affecting the poor. And you see this epitomized through breast and cervical cancer. Cervical cancer is not a non-communicable disease. It's a disease that originates from an infection. And as science progresses, we'll probably find that more and more chronic illnesses originate from an infection. Breast cancer, we still believe, as far as we know, is a so-called non-communicable disease. And by the way, that is a term we have to eradicate. Never, for advocacy or anything else, should you ever define yourself by being a non of something else. It's like rule number one in advocacy, don't do that. And for some reason, we've gone around in global health and talked about ourselves as being either communicable or non-communicable, which makes no sense anymore. But cervical cancer is a disease associated with an infection. So it's that disease associated with poverty, and breast is not. Yet, what's happened in the world today is that the majority of breast cancer cases and deaths, about 70%, and the vast majority of cervical cancer cases and death, around 90%, happen to poor women, primarily in poor countries around the world. The process of change is striking when you look across the world and compare high-income countries that you're seeing on the right and low- and middle-income countries that you're seeing on the left. Okay? In low- and middle-income countries, what happens is that the concentration of breast cancer is clear because both cases and deaths are growing faster. Okay? In the case of cervical cancer, you see a tremendous decline in cases and in deaths. And in developing countries, cases and deaths continue to go up. That's where you see this concentration, or what I've been referring to as what I think will be a neglected tropical disease, the newest neglected tropical disease, which is cervical cancer, a disease that will increasingly only affect or kill poor women around the world. And when a disease becomes a disease really only of poor and only of women, we have to think about how to protect those women from not losing any access to science and good care. If you look across our region, you see this changeover in a more interesting way, I think. So you've got some low-income countries and some high-income countries, and this is the rank order in mortality. So for a country like Guatemala, cervical cancer is the 4th most important killer of women, and breast cancer is the 18th. In Mexico, it is now true, and you'll see in a minute, that more women die from breast than cervical cancer. In the United States and Canada, breast cancer is the #1 killer of women, particularly young women, and cervical cancer is now way down on the list, which, by the way, is actually good news. That's the victims of our own success. Look at Mexico. The blue is cervical and the pink is breast. And this graph sort of became our signature graph for Tomatelo Pecho for a number of reasons. Initially, it was because we were showing that as of 2006, more women were dying of breast cancer than cervical. But it says a lot more than that. What it says, I think, is look what happened to cervical cancer. It went from killing 16 per 100,000 women to below 8. No one sitting in a room like this or any other 3 decades ago would have believed that poor indigenous women would go for pap smears. And they do, and they did, and they learned, and it's not the vaccine that did this. It's public health and women's health programs that up to now have shown that kind of a drop in cervical cancer mortality. What we do also know, however, is that what's left of the cervical cancer mortality and case burden is primarily in poor parts of our country and our region. You see a poor state on your left, a wealthy state on your right, and you see that transition much more clearly. And a state like Oaxaca, which is relatively poor, they're still battling a tremendous burden of cervical cancer, where we have all sorts of programs that can go in to do something about preventing the disease, but at the same time, they're facing this growing burden of this complex challenge of breast cancer at the same time. Change to the United States. Good news, and these are unabashedly American Cancer Society slides and data that I thank ACS for sharing. You're looking at incidence and mortality. Incidence is the dotted line, mortality is the straight line, and we're looking across ethnic groups. The really good news is what I shared earlier, a 36% drop in mortality over the last 22 years in breast cancer. But it is much clearer among whites than it is among particularly black women and also to some extent Hispanic women. So it's not that mortality isn't going down, but it's not going down to the same degree, and furthermore, incidence has now converged. Right? We're seeing even in the United States a huge divide between what poor women, Black, Hispanics, and others, have to face with this disease compared with white women. And we see our successes also generating divides. But look at what that success has managed to have happen. 41% of all female survivorship in the United States is breast cancer. Okay? Good news. A lot more work as well. But why did that happen? And this is all American Cancer Society data, which comes up, by the way, every year, breast cancer facts and figures. And that happened because more than 60% of women are diagnosed when the disease is localized and get access to treatment. And that means that these data show that there's a 99% probability of 5-year survival for that group of women. But look how it drops to 24% if you're late diagnosed, even if you have access to treatment. Now, welcome to Mexico. Dr. Moar will share much more. He is the former leader of our National Cancer, an expert in cancers. But what I know is that only 5 to 10% of women are diagnosed early with localized disease. I also know that it's much more likely that they will be diagnosed in stage 4, late stage, if they come from one of our southern states, the poor states, than the northern states. There's another divide there that explains what's going to happen in mortality even with access to effective treatment. And that divide plays out across the world. I've shown it here for the Americas. Haiti, a country being battered, as we know, yesterday and today by the effects of the hurricane, by Matthew. Low income versus Bolivia, Mexico, and finally the United States, exemplifying high-income countries. What you see on that graph is what we call the cancer divide. It's what Princess Dina Mired has said is but should not be defined by income. You have at least twice the likelihood of surviving the disease if you are living in the United States or Canada than if you're living in Haiti, and those are averages. So this divide is something that we can do something about, and what we want to get is a situation where we flatline as much as possible, where every woman in the world, if they're diagnosed with the disease, which many will be, and that's a sign of development, will have the same opportunity to access early detection and care and therefore survive. Now it turns out that all of the data that we have show that this isn't nearly as expensive as most people assume or suggest it would be. There are lots of cheap things you can do, like reducing tobacco use, which costs 3.6% of GDP to the world every year, but the cancer itself, the cancer burden, because of lost lives, lost productive lives, costs 2 to 4% of global GDP. That is because there's between 2.4 and 3.7 million lives lost, the vast majority in developing countries. And when we did our calculation, and Hector was working with me on this when we were working for the Harvard Global Equity Initiative and from Mexico, we did these calculations simply saying, what does prevention and the most basic kinds of treatment do? It turns out when you look at the cost benefit, it would mean a benefit to the world of between 130 and 940 billion dollars. That's a huge lost savings from not doing the basic investment in cancer care and control. Well, here's what the numbers look like for Canada and Latin America and the Caribbean for avoidable cancer deaths. We can talk about how we looked at avoidable, but I'm pretty sure these figures are relatively accurate. Even in the US and Canada, about 41% of breast and almost 60% of cervical, and in Latin America and the Caribbean, close to 60% of breast and more than 64% of cervical cancer deaths are avoidable. And the vast majority of those deaths, again, happen in low and middle income countries. Now, they cost the world a huge amount. We know from other research with Anna for the Women in Health Commission, the Lancet Women in Health Commission, that these women that we're losing are majority young. They're the motors of economic growth around the world. It's where we're seeing change. They're also the majority producers of unpaid and paid health care that produces more economic growth and keeps our societies and our world healthy. Losing each one of these women, any one of these women, is a tremendous loss. So what can we do about it? Well, luckily I know what the slide says. I'm sorry it flipped over. The slide tells you about the diagonal approach. And the diagonal approach says that instead of thinking only horizontally or systemically, or only vertically and about a specific disease, we need to think about synergies. We need to think about how two kinds of programs that have typically been thought of as extremely distant, another dichotomy, can work together so that the outcome is more than the sum of the parts, so that we use platforms and so that we do the kind of integration that I've been pushing for with this symposium. Here are two examples of why you can get a much better benefit-cost ratio when you think about a diagonal approach. And it's because the benefits of any intervention are spread across a number of outcomes. The simple, most obvious one is promoting prevention and healthy lifestyles. The benefits happen not just in cancer, they happen in all sorts of diseases. So count all the benefits, and it turns out that the cost of any intervention is lower relative to the benefits than otherwise. But my actual favorite example is a lot of what this symposium is all about. It's that reducing the stigma for women's cancers is not only good for getting women treatment for cancer, it's really very good for reducing stigma around women. That's what John talked about. And reducing the stigma that women face, the discrimination that women face because of gender, means that we're better able to participate in the labor market, we're better able to go to school, we're more able to defend our rights. So those interventions, those advocacy interventions, they cost something, but they generate huge benefits that ripple all through a system. But we have never actually counted nor promoted those kinds of benefits. Two other things about the diagonal approach, and it's sort of how you do it. So on the delivery side, we have examples. How do you do the diagonal? You integrate into maternal and child health programs, or anti-poverty programs, or HIV/AIDS programs, information, education, awareness, and basic interventions around breast or cervical cancer. At the health system level, on the financing side, what you do is you undertake a health reform, you finance it, but you make sure you figure out a way to include cancer treatment and earlier detection. So, a couple of examples on the delivery side. And I can't tell you exactly where it's at now, but I can tell you what we started to do. So, our Oportunidades or Progresa program covers the vast majority of poor families in Mexico. We have a whole army of health promoters, community workers who actually manage this program. And they get these manuals, and they speak to women, and they cover millions of families all over the country. Well, it turns out that these manuals had some information on cervical cancer and none on breast until very recently. And right now, I'm not actually so sure that they retain that information on breast cancer. All it takes is a couple of pages in the manual and a little bit more information to the promoters. But I'm not sure we're actually taking full advantage of it. But Mexico's program is not unique, except that it started in 1997. It's virtually national in terms of covering poverty, and it's been very, very heavily evaluated. And as a result of those evaluations, there have been conditional cash transfer programs, as they're called, promoted throughout the region of Latin America and elsewhere in the world. Miriam Steinman will be sharing with you later, and others are really experts on how these sorts of programs, through support from places like the World Bank, the IDB, and others, have actually, and as a result of the evaluations, being spread throughout the developing world. It's a huge opportunity. They're major platforms. The health and nutrition components are in exchange, typically, for the woman receiving a cash transfer benefit. It's keep the kids in school, it's what keeps the kids better nourished, and it's where you can include also information, I believe, on issues like cancer and other chronic or non-communicable diseases. Another example, throughout Latin America, and certainly in Mexico, we have this card that every woman receives when they're an adult, that's their health card, their Cartilla Nacional de Salud. And these cards are used in many parts of the developing world. And in the case of Mexico, for example, it does actually have information on cervical cancer and on breast cancer. Now, unfortunately, the information on breast cancer is incorrect. Something that we've been battling. I know, I see you looking at me, Gilberto, looking. Yes, it's incorrect. We've been battling this. Berta has been battling this for a long time. We've won a couple of other debates, embarrassing policymakers about this card. It says that you should only have a mammogram at age 40 if your mother died of breast cancer. I know, wrong information. We're working on it. But it's there. It's inputted. It does recommend earlier detection. It does recommend appropriate ways to do knowing your breasts and to look for changes. It does recommend mammograms, and it does help to manage cervical cancer and other diseases. If every national health card in every developing country included information about chronic diseases, we would be a long way there to increasing awareness and helping our primary care providers to manage these diseases better. Last example, because Laura will be speaking about this, Laura Magana, who's worked on this program with us for many years. You can train health promoters and primary care physicians to manage complex diseases like breast cancer. We've been doing it, I think, pretty effectively. It's been evaluated, and we have thousands of promoters, nurses, and doctors trained. And I believe strongly that any promoter, even without formal medical training, could have done a better job of diagnosing Juanita before she got the grapefruit and the lymphedema, with very minimal training. Now, the other example is the Seguro Popular. I said it on the financing side, you want national health insurance programs like our fantastic Seguro Popular to include complex diseases like cancers. And we did, or rather Julio and President Fox did, include cancer through a catastrophic illness fund in the Seguro Popular. Now, this wasn't such an easy thing to do at the time. There was no money for this reform. There was no specific money for covering cancer. And I remember very well the day that all of the data came through and the secretary had to choose what cancer to include first. And it was that one day where I didn't want to be sitting in his chair. The only cancer that was affordable, and it was chosen with good evidence at the time, was acute lymphoblastic leukemia in kids. It turned out to be important for pushing through all of the policy work on covering cancer in this reform. Alejandro is an expert on this. He's implemented it. We now have a number of cancers included, and breast went in 2007. Alejandro and the National Cancer have been fighting to keep expanding that list, not only for cancers, but for a number of complex diseases. That is why a woman like Juanita could actually have thought about getting free care, free treatment, including Herceptin, for her cancer. When we look at the data, these are Alejandro's data that he'd shared with me, there's been a huge impact. This is only data for the National Cancer. We don't have a cancer registry. We're working on it. Alejandro's spearheading that. He'll talk to you about it in a little while. But what we do know is that in 2005, about a third of women dropped out of cancer treatment after diagnosis, quickly dropped out as a result of not being able to fund it. And that by 2010, with coverage, it was only 10 at 900 cases. But it's the human face for me. It's people like this woman, Guillermina Avila, who had to pay and whose children lost their company and went into bankruptcy and went into poverty to pay for her first round of care, and in her second round was covered through the Seguro Popular. It's women like that that tell the country that they cannot reduce the money that's available for health insurance in Mexico, despite economic crisis, despite H1N1, despite anything else. That's where you get the voice of breast cancer speaking out around health reform and health funding and health spending. So I talked to you about a bunch of diagonal programs, but global health lacks a registry. We have never seen a program rigorously evaluated, and we have no learning exchange. So I unabashedly appeal to places like the World Bank to think about helping us to do this, to the American Cancer Society. If we could evaluate these programs, I'd be better able to tell you what works and what doesn't, as we've had to do with programs like Oportunidades. But we haven't had the funding or the ability to ever do this. And the other thing that we haven't done is when I look around the world at the many, many programs for women's health, for reproductive health, or women's rights, many of the UN programs, they have almost no information, even on cervical cancer, a little bit, and there's nothing on breast. We did yesterday, Hector and I looked and searched on UN Women and Women Deliver, the UNFPA. There was nothing on breast cancer. Nothing came up. It's not included. So we are not part of what they do, and they are not part of what we do, and we lose this huge opportunity, not only for advocacy, but for learning and for implementation. There's only one program I know of that's really diagonal. It's very, very small. Judy Salerno would have spoken to it, and Sally may mention it along with the new programs that American Cancer Society are putting forward, but there's one program called Pink Ribbon, Red Ribbon, and it is very, very small. So these are ways, concrete ways, that I think we can begin to change how we can manage diseases like breast and cervical cancer. It may seem sort of dreamlike, but I believe that there are ways to do it, just like we were able to reduce cervical cancer mortality in Mexico by half. And we can do this by working with the Sustainable Development Goals, and if we do, there are a whole bunch of these goals that we can actually hit. Through our work on women's cancers, we can change all sorts of aspects of gender discrimination that will change all sorts of the little squares that make up the Sustainable Development Goals for our world that Anna will be talking about later. And here's why I believe it. So if you've gone through this disease, and if you've seen it happen in a developing country where many, many women can't get the kind of care that I was able to get, if you've done what I did a little while ago, a few weeks ago with Carla's help, which was to stand among a group at the National Cancer Institute in Peru, where the poverty was probably more overwhelming even than the cancer that they had, you have to be an optimist and you have to be an optimalist. And I learned that from this picture. It's always how I complete my presentations, and it's because this scene happened 1 week after my last infusion of chemotherapy, where we thought that we were home free, and I got septicemia. And for those of you who know what septicemia is, it could have killed me. I was rushed to the hospital. We thought we could die. I thought that day I might be saying goodbye to her for the first and last time. And yet, only a week later, thanks to a wonderful hospital and the care of my physicians in Mexico, we were in a butterfly park in Canada. And I became popular despite my ugly baldness that my daughter perceived, that vampire that she said. I became really popular because all the butterflies wanted to sit on my head. So I turned into something that was attractive and useful and wonderful to be with from something that was not that way. And I think that the sort of hope that you can talk about when you have experiences like this with cancer can help us not only to drive through solutions for cancer care and control, but more broadly in global health and to close the divides that really plague our world, the world in which we live in today. Thank you very much.